a couple of $1,000s in debt. And we came as international students and made a life for ourselves here and have truly enjoyed living the American dream over and over and way more than we expected, to be blessed in this country. So we're really grateful to be here. Our kids were all born here. When we became citizens, we always celebrated 4th of July with our kids. But when we became citizens, we shared with our kids that this is a lot more meaningful now because we just became citizens. And my son turned to me and said, "Well, Dad, you kind of are Americans, but not really Americans. You and Mom may be half Americans, but we will let you." So I was really hurt as a parent. I was like, wow. My son has these views about immigrants and they're his parents. So I got really concerned, so I've been sharing with my kids about some of that too. So you probably appreciate the joke, you see the joke, and it was a joke, but it was also very hurtful. To see my own kids with that sense of privilege, it was pretty concerning. So, anyway, I really want to, you have a lot of slides in my presentation, and you also have 2 handbooks that are produced by SAMHSA. They're free. And I'll share with you some of these resources. I want to give you a sense of what I do in a 2-day training with counselors in different agencies within a 4-hour span. So I'm going to select and be selective through the presentation as to what I share with you. And I'm going to try to move fast through some of it too. My goal is that today we go through the theoretical underpinnings of this model. What's it made of? I'm not going to spend a whole lot of time. I was kind of, eavesdropping a little bit at breakfast, and all you guys seem very articulate and talking about different theories and concepts and stuff like that. Some of you are talking at breakfast, so I'm not going to, dummy it down for you to make it boring. So I'm going to move fast through the theory aspect. And then I'm going to talk a little bit about how do those come together into this model. And then we're going to talk about stages of addiction and stages of recovery and what's important. And throughout the presentation I'll say this is how I do it with my clients. In 2006, when I was part of the Minority Fellowship, I was working as a residential counselor in a residential facility for substance abuse, and I was just bored, to be honest with you. I wanted something more. I loved my job, but I wanted something more, and I felt like in a box. So I went home one day to my wife and I said, again, that was one of the American dreams for me. I got a full-time job, she had a full-time job, we bought a home, and all of a sudden the husband comes home and says, "I want to quit my job." And she goes, "What do you want to do?" And she's always known me. I've been pretty adventurous when I was back home in terms of managing businesses and stuff like that in Albania. I said, I want to open up my own place. I want to have my own counseling center. I want to model it based on European-style coffee houses. Free coffee. And you just come in, we can talk about your recovery. And I want to focus on addiction. Partly why I focus on addiction and recovery has a lot to do with my own family history. My family has been pretty crippled from addiction. I've been fortunate enough not to have struggled with substance abuse, but I have struggled as a family member. And so that's why I kind of have picked this as my niche or as my service or whatever you want to call it. So I started my agency while going through the fellowship and quickly connected with some programs funded by Access to Recovery grant of SAMHSA. It funded back then many states. Now it only funds like 5 or 6 states. But I've been a director of one of these programs for a long time, and I developed it from scratch, and it was the best learning experience for me. One of the things that is really important in the field is you're going to be required to say, I use evidence-based models. And it's not just a requirement, you should want to. if you see a client, you want to say that the models that I use are tested and true, and they work for most people. And so one of the things, if you look at common factors, hope is a big deal. It accounts for 15% of a client's change, right? So you want to be able to give them hope through the evidence-based practice that you have. I should have that on?
I think it is.
Okay. I thought that was loud enough.
I want to make sure the video picks you up.
Okay, I did have one. Is that louder? Better? Okay, great. So you kind of want to use evidence-based practice, and this is one of them. I'm going to start by saying it's probably one of the best manualized models that I have ever used, that I've used a lot of. I use it in training all new substance abuse counselors in my agency. And I use it, I've done trainings in the Midwest all around with this, and we've used these manuals. And the other added bonus that it has is that if you work with clients that struggle with addiction, you can order clients' workbooks through Samsung. If you go under their publications, and they're free. And they come right to your door, and you use them with your clients. And so that's what we do. Actually, my staff are really good when Samsung is out of publications. They will put their name on a waiting list. They'll be notified once they're printed, and then order them and bring them in with clients. So if you invest in this, you want to, yeah, there's a ton of resources out there to do. So, well, let me see where I put my clicker. Okay. So my hope is to describe the model and then share with you just how it's done. We're going to do some exercises tomorrow to how it's really done. How many of you are familiar with Dr. Nora Volkov? Anyone? Anyone knows who she is? I really hope you do after this presentation. She is an amazing expert on substance abuse, and she's the director of the National Institute for Drug Abuse. And her research has been groundbreaking when it comes to addiction and addiction treatment. She is from Eastern Europe and has an accent. She's not Russian, but might have some connections with Russia, I don't know. So, but I wanted to introduce her to you, and I hope that you look up into her work. Let me make sure it's not mine. It probably was. And let's see if it works now.
We've gone through this for 3 years with her. She's been in a rehab place
Does it come from?
before, but
It needs to be louder.
she made a choice. Choice was she wasn't ready for that. She wanted to leave. But she ends up relapsing. She ends up drinking. She's taking drugs. We've tried everything we could to help her, but it's not so much of us helping her. It's her trying to help herself.
It's hard to understand that someone loses control, that you cannot regulate your own behavior. It's very hard for us to understand that because we do.
It's
Called
not
freedom.
one.
Well, in addiction,
So,
part of that,
yeah, let me replay it. I had not connected the sound things.
Okay,
Here we go.
We've gone through this for 3 years with her. She's been in a rehab place before, but she made a choice. Choice was she wasn't ready for that. She wanted to leave. But she ends up relapsing. She ends up drinking. She's taking drugs. We've tried everything we could to help her, but it's not not so much of us helping her, it's her trying to help herself.
It's hard to understand that someone loses control, that you cannot regulate your own behavior. It's very hard for us to understand that because we do it. That's what we call freedom. Well, in addiction, part of that ability is disrupted. The area of the brain that allows us to do free choices is not working properly. For many years, one of the discussions has been whether drug addiction is a psychological disease or whether it's a physical disease. And really that neither has helped the field, because ultimately, what is a psychological disease? A psychological disease is a disease that comes out of our brains. In the past, when you had an emotion and you were sad, or you were very happy, or you were very angry, you said, well, that's psychological. But there is an area in the brain that is responsible for us feeling these emotions. Just like there is an area in the brain that is responsible for me to be able to move my fingers. It's just different areas of the brain. So, is drug addiction a psychological or a physical disease? I would say drug addiction is a disease of the brain that translates, that disease translates into abnormal behavior.
It's pretty complex, but we may not have a lot of answers. But what we know is that one of the common definitions of addictions that's used, it's that it's chronic, it's a relapsing brain disease that's characterized by compulsive drug seeking and use despite harmful consequences. And it's a struggle, it's a struggle. My wife, all of us as a society need education to understand addiction. My wife is one of those people who did not come from a family where addiction was present or substance abuse, and she's like, how come somebody continues to do what they do when it's harmful for them, when they should just kind of say no? Or once they understand that it's the wrong thing to do, they should stop it. She doesn't understand the concept of this struggle that addicts go through, that that they could relapse, and despite harmful consequences, they could continue to use. And we don't get that part of this brain disorder or disease, whatever you want to call it. You go a little bit more of that
As she
same
got a
footage.
little older, became 15 and 16, things started to fall apart. And the more she was given freedom to make her own choices as she grew older, the worse choices she made and harmful choices for herself. And so I'm interested in your research because I would really like to know what happens in the brain. What triggered this?
As we know more and more about most of the diseases, this is what we're coming to understand, that for most of the diseases, there's that interaction between the genes and your environment. So there are some people that are more vulnerable for drug addiction. It's much easier to explain a disease of the heart where the heart just pumps. So if the muscle is not working, the heart cannot be pumped, and you don't have enough blood. The brain is very complex. It regulates our emotions, it regulates our thoughts, our decisions. And so when certain areas are not functioning properly, it manifests in much more complex ways than a muscle not contracting and pushing the blood. And so that is why it has been so difficult to translate this drug addiction as a disease of the brain.
I'm having a difficult time believing that addiction is the same thing as heart disease. I'm having a hard time believing that it's a disease.
But let me throw it back at you, and it's actually one of the reasons why people exactly many times have trouble like conceptualizing drug addiction as a disease is because they say, well, the changes were not there before they took the drug. Had they never taken the drug, they would have never become addicted. But the same thing is for hypertension. You are actually going to, or for diabetes. There are certain people that will never become diabetic if they always kept their weight within a certain level. And so their doctor can tell you, don't eat that, and you will not develop diabetes. So all of the diseases have a certain level of behavior that facilitates that it's development.
I'm more in tune with what you're saying, but I'm not there yet. Let's put it that way. I'm not there yet. I'm sorry.
No, don't feel sorry. I think it is important be convinced that yourself. And as I say, it has been a concept that is difficult for people to accept because there's a notion that the person voluntarily is taking the drugs. Then you start to say, well, the person started to take the drugs, or they are doing it because they want to feel good. Well, a lot of people that get addicted stop feeling good about drugs a long time before, and they're still taking it.
So we're not going to get stuck in the debate, right? We're going to move on, but the premises of this model is based on this concept that this is a brain disorder and that we have to move. And the concept of the heart, you know, they do these brain images now. It's just fascinating with the research, where you can see, you know, the differences just in terms of coloration between the two organs. Let's say if a heart, if it's diseased, you don't see the blood flow. And same thing with someone who's used cocaine, for example. Their brain actually looks very different in terms of how it fires to the brain of someone who's not using it. And that's where they base some of these decisions. What do we know is that it's complex, and we do know that there's a sense of biology or genes that interferes. There's a sense of environment. It doesn't mean that if you're a child of an addict or an alcoholic, you automatically become an addict or an alcoholic, but you're more at risk. So we do know, and we'll look into that later, that if one parent is addicted, it's most likely that their child, if one parent is addicted, is about 4 to 5 times at risk to become addicted themselves. But if both parents are using, that these risks double, up to 8 plus times at risk. And that's in your handouts too. But we do know that when people start experimenting with drugs, there's some components that really affect someone into developing an addiction more than others. You know, for example, the earlier you start, the more of a chance you have to become addicted later in life. And that has to do with our brain development, or the way you administer the drug, the way you use it, what kind of drugs you use, how often. And then we have these family aspects that very little people, you know, that's one thing I like this model. It's, as you see on the manuals, you have a manual to work with your client individually and in groups, and they have a manual to work with their family. It's one of the models that really values our profession and what do we bring to the table in terms of working with addicts and alcoholics. But chaotic home, you know, parents use, I was sharing with Arnold earlier, it's maybe that's a sense of getting old too, and I've heard that before, and now it doesn't feel good I'm there myself, but I'm seeing the children of my clients when I first started doing, so that's my sign of getting old maybe. But the other concern is that, and what I'm learning from them, is that they started with another sibling, or they started with mom or with dad. And now we're going through family therapy of the guilt and shame that both the parent feels, you know, but also the frustration that the child feels that this mom or this dad, how could you introduce me to drugs? And you may sit there and say, that is awful. I mean, that person has no common sense. True, very true. But that's how addiction really can impact somebody's life, to the point to where they lack judgment. They don't know, and they feel like this mom feels like she was developing a connection with her daughter. It wasn't that she wanted to hurt her daughter. And so it's a lot of really ways how it can really impact us. But brain mechanics is one of them, but a lot of it really has to do with the earlier you start. And so the other piece that's really important when you apply any model is diagnosing. Not everybody that walks through my door is struggling maybe with substance use at the point that they have developed an addiction. And I like the DSM-5 classification now where it talks about severity. But it's really important to diagnose them correctly because you put them in the wrong treatment. Not everybody that comes through needs an intensive treatment model. Not everybody. So cookie cutter models don't really work. So you want to be able to diagnose them correctly. I have people that I work with that they want to learn how to manage their drinking. Or I have people I work with that went through a life stressor and now they're just kind of using alcohol, for example, as a way of self-medicating. or going through those stressors. So you want to diagnose them correctly. But the majority of the people that I work with do have a severe substance use problem, probably multiple substances, and most of them on probation and parole or have been to prison. That's been the population that I've mostly worked with. Now, let's go through some myths. And I promise you, so far you've heard two people with an accent in my presentation, me and Dr. Volkov, and there will be people without accents too. So I'd like to ask you, some of you guys, to maybe read some of those myths. I want to go through those real fast. So who would like to help me out? Maybe one from this table over here. Can you read the first one?
Addicts are bad, crazy, and stupid people.
Raise your voice real high so they can hear you back there.
Addicts are bad, crazy, and stupid people.
All right. Who's going to read the next one?
Addiction is a willpower problem.
Okay.
Addiction should be punished, not treated for using drugs.
Okay.
People addicted to one drug are addicted to all drugs.
Okay.
Addicts cannot be treated with medication.
Raise your voice. I can't hear you. That means they can't hear you.
Addicts cannot be treated with medications.
Okay.
Addiction is treated behaviorally, so it must be a behavioral problem.
Okay.
Treatment. Treatment and/or recovery support don't work.
All right, so I have another set of those in the next slide. Let's do a quick discussion of those. What's up here that you've noticed that it is something that people talk a lot in the field and debate? Well, pick one. Yes.
I've heard a lot, like addicts cannot be treated with medications.
Yeah, yeah.
The notion of willpower and control.
The notion of willpower and control, yeah, it's a big one. And so is MAT, medication-assisted treatment. We know that it works in combination with psychotherapy and other methods of treatment. It doesn't work singly alone, you know, but sometimes we want that magic pill. But this issue of willpower has been a big issue between sometimes the treatment agencies and the mutual help groups as well. Great. All right, now crazy and stupid. There's a little laugh. One of my clients broke his arm because he was surfing in the back of a pickup of his friend and fell over. And you could look at that and say really stupid, but he was so strung out on math. It's unbelievable. And this story I'm sharing with you is that today he's a substance abuse counselor, a peer support or recovery coach, they call him more of the time. And he talks about it, how drugs impacted him to that level, to that degree, that he brought so much, harm to himself, from, well, we could look at something like that and say, he's really dumb. But it's not, the stupid piece. All right, so help me read those ones real fast.
Alcoholics can stop drinking simply by attending AA meetings, so they can't have the brain disease.
Okay, thank you.
You have to want drug treatment for it to be effective.
Okay,
Treatment for drug addiction should be a one-shot deal.
all right.
We should strive to find the magic bullet to treat all forms of drug abuse.
Okay,
People don't need treatment. They can stop using drugs if they really want to.
okay,
Nobody will voluntarily seek treatment until they hit rock bottom.
all right. So what's up here that just stands out to you?
You have to want drug treatments for it to be effective.
Okay, we do find out, that's a good point. We do find out through a lot of research that even those who are mandated to treatment fare just as well as those who we say willingly come. Which, by the way, I've been doing this since '93. I've never had someone just dying to come see me because they wanted to get sober. Somebody gave them the boot. It may be a family member, it may be a child, it may be a probation officer or a judge. Yeah, you had your hand up?
Yeah, I was going to say, a lot of times people say, I can stop anytime if I want to.
Yeah. And they do have a lot of markers, like first child, second child. Like I just started doing a couple of recovery court clients. Drug court, now there's a lot of language change in addiction treatment. We're moving to use more of the positive word of recovery rather than drug treatment. So this one client, I was doing an assessment the other day, he didn't see a reason to quit. The judge wanted him to, and he did not want to have those things. So, but as I was going through assessments in a couple of sessions, I developed a genogram. I turned that in front of him, and he said, "Oh yeah." He said, "You know what's weird?" I said, "Yeah." He said he had 6 kids. He said every time a child was born, I really wanted to quit. I just never made it, right? Or he'd been to multiple treatments. And sometimes it's just not the right time, I don't know, the components have to be right. But it does take some time. These are just some myths that people have that really kind of hurt the field, hurt the addiction, or finding that magic bullet. We just want a pill to treat everybody. That's very concerning. All right, so the matrix model was developed in California, where most things seem to be developed. The nice part is that the first cohort of the Minority Fellowship group, including myself, which was a part of it, is that we went and attended a training that was organized by them at the University of San Diego. And we met with Richard Rawson. Dr. Rawson came and greeted us and shared with us the MFP fellows. And then later on, I did go to more trainer of trainers that they offered. And that's how I developed an interest in the model and became a trainer as well on the model and used it at my agency. Traditionally, it was developed to treat methamphetamine. Sometimes grants are tied to specific things. But I can tell you that it works just as good, and other research has been showing it, but also in the clinical aspect of what I see. It really works just as good with anybody that's an alcoholic or somebody starting with heroin or cocaine or whatever. It's a model that fits, the bill for that. At the time, it was compared to treatment as usual, and not a specific model. And these are some of the statistics that it had, that people were staying sober. They were more likely to stay sober if they were going through groups than if they weren't, or if they attended some other groups. So fairly, it was showing some positive results, and that's how it kind of developed itself as a evidence-based model. It was tested with thousands of clients, and it has continued to be tested. These were data from early 2000, but right now it's one of the most preferred models in recovery courts or drug courts around the nation. And so it's because it has the components that it needs. It has both individual and family therapy are part of it. The clients go through some early recovery skills, and then they move to relapse prevention. Throughout that time, there's family education that's going on, and we'll go through those in detail. And there's an encouragement for social support. And a big one is that people have to do drug testing or urine testing as they go through the program. And some of this is not to catch them. The way we actually frame it with our clients in recovery court where I'm at is that we say you're building evidence. You're proving other people wrong. Because I had one of my clients who said, "Man, I'm going to run out of pee. One of these days it's..." and now he's one of the biggest proponents of saying, clean pee, but a clean UA or negative urinalysis. So, but you got to be able to reframe it with them in a way to where it makes sense for them. So he's proving to the world and to the rest of the people that he's clean. A lot of times we doubt. Have you used? You're acting weak. This and that. Or no, you haven't really been staying sober. And for him, it's just evidence that he develops that he's staying clean. So it depends on how they look at it. The model really has several theoretical underpinnings. Motivational interviewing is one of them. And we're going to look at maybe a little bit about what that means and what it. How many of you are familiar with motivational interviewing? Oh, great. Yeah, a lot of you. So most of you. So, and the goal is, you know, really abstinence. And it's focused. Another component for it is CBT. It has a lot of questioning around them really trying to develop ways how to stay sober and how to change their thinking. It has some family support and engagement that's involved in it. It's very different from inpatient in that inpatient is gradual. I'm sorry, it's fast and it's episodic. It's like, what, 21 to 30 days. And this is gradual. You go through at least the minimum through the models of about 16 weeks, which is about 4 months. And then you taper off into more supported recovery. So it's pretty intense, but you look at the progress that they make through that time. Now, some people stay longer, you know, because they move up or down the system. And we'll look at those. We'll look at those things. And the reason I put that in there is because people take this model sometimes and use it in a residential facility. It's good in the sense that at least you're using something that's manualized and given some education to people in your treatment center, but it's not designed for a residential facility. It's designed to be more of a model that's used in outpatient setting. All right, so we'll look at these cognitive behavioral, maybe contingency management a little bit, MI, family systems. We'll look at these theoretical underpinnings real fast and then we'll move on. So let's go with this.
Cognitive behavioral therapy is a set of techniques that helps you learn day to day how to get sober and how to stay sober.
Yeah, I had no idea that I could actually quit at some point, get sober. I didn't think it was possible. But
It's a teaching, it's a coaching, as opposed to therapy, which is looking at the long-term reasons for why you got addicted in the first place. Cognitive behavioral therapy focuses on how to not use drugs and alcohol right now and learning skills that will help you not relapse and stay sober in the future.
So the guy that was talking was Dr. Richard Rawson, one of the developers of the model. So it really, a lot of times in cognitive behavioral therapy, a lot of addicts that I've worked with feel they're worthless and that they don't amount to anything and that they're never going to make it. They've developed this sense of hopelessness that they just keep on using because they see no way out of the misery that they're in. And sometimes, you know, CBT is really kind of based on you are what you think. And being able to help them change that thinking is extremely important. You know, or when you look at people why they relapse, they've developed certain pathways that we need to change into something different, you know, and help them to totally, even as simple as not going to cases on DD Highway to get gas anymore. You have no idea where that is, but it's a gas station in one of your streets where maybe the drug dealer is present and this is who kind of feeds me the drugs every time, and that's where I buy, and it's really important that I don't go there to be able to do that anymore. So, so you focus on those, just changing those assumptions and those cognitions and beliefs about themselves and maybe behaviors that they do. So the role of the therapist, and I'm not going to spend much time on this, but the role of the therapist is really to teach and coach and support and redirect the person as they go through these new ways of thinking and acting when you're using this. Contingency management, big deal, big deal. They use this in recovery courts and drug courts. I begin with the assessment to do contingency management. How many of you have heard of something called Addiction Severity Index? Okay, good. It's one of the really the biggest tools right now that's used, and there's one that's called ASI Motion Video, MV. So the client sits on the computer, they do the assessment, and it gives you a really nice printout report for you as a clinician, where you can then begin to do your diagnosis and develop a treatment plan. And I use the MV model. So when the client is done, there's some of my staff who are lazy and don't print. Now, don't edit that from the tape. And I don't like it when people do that. It takes only a minute. Only a minute. And I'm not talking about you guys or anybody else. I'm talking about my staff. Okay? And I love them. But some of them are lazy to the point of not being able to print the certificate, which will state, you complete, congratulations. You just completed the Addiction Severity Index. Why is that important? I print that out and I give that to the client. Yeah?
I mean, it's kind of a way of actively acknowledging that they're like actively engaged and have kind of taken a first step and to kind of give them some hope for continuing a journey to slowly to change.
Excellent, excellent. What else? What else is important? We give them a certificate.
Serve as a reminder, next when you're in a tough spot, they can look back at the certificate and remember they took the first step.
I took the first step. I completed something. I already started that journey in terms of recovery. Yeah, and it's all of these are really great points you guys make. I have sometimes clients who look at the certificate and they say, this is the first one that has the word achievement in it. The first thing I started and I finished. Now, in reality, it isn't, right? If you're a solution-focused therapist or any therapist, you'll look at the exceptions and find out they've accomplished a lot more other things in their life. But how they feel is a whole different matter, So it's a big deal. And when they stay sober for a day or two, we have a bowl, the fish bowl, and I have purposefully, I make friends with a lot of restaurant managers in my area. And I get a lot of certificates to eat free. And they know that I'm not using them for myself or my friends or my family members. So they give them to me. And we put them in there, and every week